the Senior Improvement Advisor and the Delivery Lead on the Healthcare Improvement Scotland's Personality Disorder Improvement Programme. It's hard to believe that this is actually the final of this type of webinar within our learning system. We've covered lots of really interesting areas over the previous webinars, and I'm sure that this one will be no different. We were really keen when we were selecting topics to consider that crisis and unscheduled care was one of the ones that we would make sure that we were able to fit into the programme. There will be a final online event as part of the learning system where we will speak a bit more about our final report and the recommendations for phase 2 of this work, and that's on March 28th. So anyone that's attending this event will receive links for that. Can we move the next slide on, please, Andrew? There's me. And another slide. For people that are not that familiar using Teams, some instructions there. What we would do is encourage people to use the chat function down the side of the right hand side of the screen. If I see lots of people introducing themselves just now, it's fantastic to see so many people come from all over Scotland. That's fantastic. If anyone has any questions for the presenters, please put the questions in there. We'll try and ask as many questions of the presenters as we can. Any questions that we're not able to put to them, we will do after the event, and we'll do a mail out with a comprehensive question and answer session. Yeah, everyone's automatically muted. Please keep cameras off just now. It helps preserve bandwidth. I understand. Next slide, please. And we will be recording the webinar, and it will be available to view afterwards or share with colleagues who have not been able to make it. It'll be on the YouTube link. And next slide, please, Andrew. So today we're looking at crisis and unscheduled care. We've got a load of speakers. We are going to start off with speakers from NHS24 Mental Health Services. We'll have a Q&A session shortly after, or just after them. We'll then look at the Mental Health Assessment Unit in Greater Glasgow and Clyde, and Compassionate Distress Response Service run by GAMH, and we'll have a sort of combined question and answer session after those two presentations. Professor Andrew Gumley is then going to talk about remote approaches and psychosocial interventions, and we're going to have a presentation on mental health and crisis from colleagues in Greater Glasgow and Clyde, with a combined question and answer session after that. Then we'll have some polls round about the evaluation of the webinar at the end. Okay, so miraculously, I think I'm a minute under. So it gives me great pleasure then to hand over to Lauren Kennedy and the team from NHS24. Thanks.
Hi there. So my name's Lauren Kennedy. I am lead nurse for mental health and learning disabilities here in NHS24. I'm joined this morning by my colleagues, Lisa MacDonald, Operational Manager for our Breathing Space Service, and also our Senior Nurse for Mental Health, Kath Robertson. We're absolutely delighted to be invited along to chat about our mental health services here in NHS24, particularly around our support of people with personality disorder, and how we engage and how our services, I guess, have developed, probably at pace over the past 3 years. Next slide, please. So this just gives you an overview of our services here. We have our main mental health hub, which is accessed through 111. And again, I'll come on and talk a bit more detail around that in further slides. We've got our breathing space team who are accessed through a separate number. And we also have our Living Life telephone-based psychotherapy or psychosocial intervention group. We also host a National Wellbeing Helpline. Again, that was commissioned by Scottish Government throughout COVID, and that's for our workforce, those that are employed through NHS or health and social care. Got a couple of other services as well, which I'll come on and chat a bit more about. We have our digital services to support our mental health and wellbeing. We host Scotland's national digital platform, which is NHS Inform. Next slide, please. This is to give you an overview of our mental health telephony services, and again, give you an idea of some of the data and the call volumes that come through. You'll see there, our breathing space team are taking up to sometimes around 12,000 calls each month. Our mental health hub, again, this is variable, the data here. At the moment, I think we're up at around 10,000 calls each month. Living Life, it's badged on here as our CBT support by telephony. Again, we do have opportunities for guided self-help as well. And at the moment, we're over probably 100 referrals each month. The National Wellbeing Helpline that I mentioned there, I guess as we've come through COVID, we're coming out of that now, most boards have their own helpline or supports in place for staff wellbeing. This was more of a kind of belt and braces approach. It was a national one. I know boards did a buddy system where they would, like Lanarkshire would maybe do Glasgow, vice versa. This is the overarching one. And again, we could probably get minimal calls, probably less than 10 each week to the national helpline now. We've got a pathway in with Police Scotland, and you'll see there from the data here, 200 calls per month. Again, that's probably increased over the last month or so. I'll talk more about that when I come on to those slides. Distress beef interventions, again, we're the national referrer for distress beef intervention. We had started out with a small test of change with 4 pilot boards, but that very quickly accelerated throughout COVID-19. And at the moment, we're making over 500 referrals each month. Next slide, please. This is our online mental health offering. Again, majority of this is hosted through NHS Inform. Again, we're able to evidence that obviously NHS Inform will talk more about what's on NHS Inform, but what we're seeing at the moment is, we're seeing around 600,000 plus hits each month around mental health and wellbeing. We have also on there our surviving suicidal thoughts. And as it says, that these are video stories by survivors, and whether that's people who've attempted suicide or those that are affected by suicide, that could be family members, friends, carers, colleagues. And again, those videos, we've only recently launched this, those videos are seen around, 205,000 views each month. The surviving suicidal thoughts work came around through initially our engagement with NHS Ayrshire and Naven, who had seen a spate of suicides of young people in a particular secondary school. That evolved quite quickly, engagement quickly with Scottish Government around what could we do to intervene before it got to that point on a national level, and something that was digital. Therefore, we looked at Google AdWords and how we could intervene at that point. And what we were finding was what information was telling us was people were Googling how to complete suicide. The majority was around 2 in the morning. And at that point, so if that happens now, they're automatically aligned through to this surviving suicidal thoughts stream, which then takes them to videos, self-help, telephone numbers, help is available real time rather than straight to how to complete suicide. Our breathing space team, we've got Lisa on, our operational manager for breathing space. Breathing space piloted web chat. That was before COVID, and that certainly excelled. We now have that as a substantive offering within our mental health services web chat. So that's run by our breathing space service. It's at the moment seeing over 500 chats each month. And I think the data's telling us that the majority of people that use that are probably no surprise as young people, those under 30 and predominantly male. Next slide, please. So moving on to our mental health hub. Next slide, please. You'll see here, this is a basic flow of what our mental health hub looks like. So callers to NHS24 dial 111, and then at the moment you press 1 for your mental health or wellbeing, and you'll come into our mental health hub. Mental health hub is staffed by mental health nurses. We have probably 12 mental health senior charge nurses. Our target is around 30 mental health nurses at band 6. We don't have that many just yet. And we have around 100 psychological wellbeing practitioners. So our psychological wellbeing practitioners are majority are psychology graduates with experience of mental health working. So the first port of call is when people call into our service is the phone is answered by a psychological wellbeing practitioner who probably 7 times out of 10 will complete that call with the person. We carry out a full psychosocial assessment of every caller to our mental health hub, and that can take up to an hour. It's a full risk assessment. It covers, public protection, housing, support networks, diagnosed conditions, wellbeing, all aspects, medication they're on. We carry out that full assessment and we share that assessment with each territorial board. It will come back through unscheduled care down a DASTRA to each board. I'll talk more about how that came to be in a further slide. Anyone can call our mental health hub. When we set up the hub, we didn't set it as a mental health crisis service. It's very much unscheduled care. And in that, there is wellbeing, there's mental health, there's mental ill health. It isn't prescriptive as to why people call. And we are aware, we work really closely with each territorial board, and we know that in the out of hours period, quite often people are signposted to ourselves as part of their care plan, their action plan. We're still evolving, we're still trying to recruit to our service, probably not dissimilar to other boards. So we're not fully staffed yet, but very much working on it. We are engaged around some of the complex callers to our service with territorial boards. I guess a fact about us is it's maybe not often known. We don't have access to patient records. So if patients or callers are engaged with territorial boards, they'll have an RMO and a robust care plan. We don't always have access to that. We only have our own notes at NHS24. And again, no surprise, but the National Digital Strategy, that would be our long-term vision, that we're able to access all patients' care plans and notes. At the moment, we can't. What we can do is have a look at the key information summary, which is populated in each record. But again, that needs to be populated by the GP, and that would rely on the local team asking the GP to put that on. And again, that also has its complexities around how that's governed. So more often than not, we are assessing people over the telephone and just going through a full assessment and making a decision real time without that information. So it's very much person-centred. You'll see along the side there, we've got some of our pathways. We're working really closely with Police Scotland, Scottish Ambulance Service and the Distress Brief Intervention Team, again in line with the previous or the current mental health strategy around enhancing unscheduled care, with there being no wrong door, right care, right place. So if you phone Police Scotland, they'll carry out their own triage, and we're now working in partnership with them to get people through to our mental health hub for a full psychosocial assessment over the telephone. If deemed appropriate and the usual risks are ruled out. Scottish Ambulance Service, we're continuing to work there around paramedics and ambulance technicians. Maybe if they go out to see someone at their home and they think, this is a mental health call, you don't need to go to hospital. However, you would benefit from a full mental health assessment. They are encouraging people to contact our mental health hub real time for a full assessment, and again, onward signposting or intervention. Our PWPs are skilled in psychosocial interventions. They are supervised by mental health nurses. If there is a clinical element to that call, around medication or mental ill health, the call can either be taken over by a mental health nurse, or the PWP will be supported to manage that call. I think we'll move on to our next call. Call outcomes. This is just to give you an idea of some of the statistics we've already pulled together. We'll see here, this is up until January this year, 48% of the calls were resolved without any need for onward referral. So people calling the hub will generally provide some form of intervention, reassurance, support, real time. So up to 50%. I think that varies month by month. Some months that came up at 80%. We're not referring on to, we say onward referral, we're not referring on to police, A&E, back to the territorial board, GP. We're managing those in NHS24 Mental Health Hub. 26% referred to the local primary care service. In the in-hours period, it's probably important to say at the moment, the pathways aren't the same as those in the out-of-hours period. So in the in-hours period, we can refer back to their GP, police, ambulance, A&E. In the out-of-hours period, there's more robust pathways set up. And again, we're sitting at 7% at the moment referred to the Distress Brief Intervention Service. Next slide, please. Well, I spoke to you there about our full psychosocial assessment that we carry out in NHS24. When I took up post, worked really closely with our partners, the NHS Association and Naven, around their risk assessment framework. And again, they were very, very supportive of us in NHS24 around a framework that fitted the role and function of our PWPs, nurses and mental health hub. We scoped out other boards, but this was the one that seemed to fit us in our service and what we were hoping to achieve. Again, as I mentioned, it covers mental health, treatment people are on, previous suicide, self-harm, public protection concerns around their support network, substance use. Next slide, please. Again, looking at their social and personal risks, thinking about their housing, their occupation, any other issues, and our overall impression. You'll see down the side here, we use a RAG scale. Again, we work with psychological wellbeing practitioners who we have a robust induction. We have robust competency frameworks around their learning and development. Therefore, for us, we use the RAG scale. So if any of these things, there was any risk, they would immediately be read, and that would then indicate that it would involve a mental health nurse and they would need some form of onward intervention rather than us trying to manage that in-house. Next slide, please. So thinking about the main call reasons to our mental health hub, here in NHS24, you probably know we are data rich. We record data and everything. So the main call reasons, again, no surprises, are suicidal thoughts, anxiety, low mood, psychosis, and medication queries. I think what we're finding at the moment is with the cost of living crisis, there's definitely more people phoning around relationship issues, housing, money worries, job security. We've also had an increase in calls around bereavement and loss. So we are, as I mentioned earlier, very much set up as a wellbeing and mental health service. Next slide, please. Spoken to you briefly about our DBI pathway. Again, so if a caller was to contact our mental health hub, we carry out a full assessment and we would check with them whether they've been through DBI before, whether they'd found it helpful. We've got some case studies on some of our people that we've referred to DBI and the success that that's been for them. So the positives around that are being picked up the next day, receiving up to 14 days intervention, and that's more about distress rather than mental ill health. Next slide, please. Onto our Breathing Space team. So most of you will know Breathing Space. The Breathing Space brand is certainly well known throughout Scotland. Breathing Space, next slide, please. Breathing Space also went through a period of expansion throughout COVID. Again, we doubled our staff. I think that was around the time that Lisa and myself took up post. We're still continuing to recruit into Breathing Space. We have a team of advisors and supervisors. Breathing Space calls involve people who are experiencing suicidal thoughts, depression, anxiety, self-harm. Similar to our mental health hub, we're not exclusive as to why you would call our service. You can contact us and we will offer listening, advice, and signposting onto other services if needed. Breathing Space can refer into our mental health hub, an internal transfer through if the person was significantly mentally unwell. They would transfer through if they needed onward intervention. At the moment, our Breathing Space team don't take caller details. It's badged as a confidential service, so you can contact Breathing Space without giving your details. However, if there are risks identified around public protection or mental ill health, then we'll encourage the caller to give their details so that we can get adequate help and support to them. We're immensely proud of Breathing Space. Obviously, they've been with us since 2004 and award-winning, particularly around digital health and our web chat service. Next slide, please. You'll see here that we work alongside community-based organisations, such as Network Rail, Scottish Rugby Association, the drinks industry, and again, a lot of our work there is around promotion of suicide prevention. And you'll all be aware of our bench projects. You'll see benches in universities, train stations, housing developments, and they've all got wee plaques on them about taking time for breathing space and our contact details. Next slide, please. Living Life is our telephone-based cognitive behavioural therapy service. Next slide, please. So, Living Life is for those suffering from low mood, anxiety, and mild to moderate depression. It's a low-level cognitive behavioural therapy service, and we did have some posts for mental health practitioners previously. Next slide, please. A Living Life service is a self-referral, or in the past, GPs sometimes refer in. Sorry, I'm just checking the time. I've got like a minute and a half left. Next slide, please. Next slide. I mentioned around our wellbeing helpline. We're probably seeing less calls coming into that now. As I mentioned, boards are set up around wellbeing of their own staff. It is open to health and social care, but the majority of callers to that were females working in ITU, and the most calls came around in between lockdowns and increases in COVID cases. And it was a younger population that were contacting the helpline. Next slide, please. Digital resources, next slide. So here on NHS Inform, we have 13 self-help resources, and they go from sleep right through to obsessive compulsive disorder. We also have mental health topics on there, on anything that's contemporary. We've worked with Scottish Government, Police, Ambulance around Together Let's Care campaign, and there's lots of information on there. We tend to find that a lot of our partners across health and social care signpost to NHS Inform. We have a team on NHS Inform who keep all the resources contemporary. Next slide, please. Next slide, please. And there's a list there of our resources. Next slide. And the next slide. Again, here is our Mind to Mind project around, some of the video resources that we have on there. Oh, I've just made it 20 minutes. So we'll just go to the last slide. Thank you. I guess that was a whistle stop of our unscheduled care services. It was always going to be no mean feat to do that in 20 minutes and give it justice. I hope I've given you a reasonable depth to understanding our services. I have Lisa with us and Kath, and we've got 10 minutes for any questions. So I guess that'll be meaningful to you to have a wee think about what we do and what's important to you. I know the session is on around people with a diagnosis of personality disorder. I guess for us to say, I hope I've themed that throughout our mental health services. We don't do anything differently. People with personality disorder, you come in as an individual, and we will support you and introduce coping strategies, interventions, signposting, as we would with any other caller or with any other condition. It's very much person-centred, and we don't have access to records, so we go case by case and make clinical decisions real time. Thank you.
Take a breath now, Lauren.
Well, that's talking. Well,
that was
20 minutes goes quick, doesn't it?
It does. That lots of information in there, and we've had a few questions come through in the chat. Usefully, some of those questions have been answered in real time. Colin, if you could put any questions you've got in the chat, that would be great. So we've compiled some of the questions that haven't been answered yet through the chat, but before we go to that, just to say, Dan Warrender had made a comment there about a question that was somehow asked in his name, but it wasn't him, but the reply went back to the person who had actually asked it. So I think there's some kind of coding glitch at that point. I don't know, pixies in the internet or something. I don't know. I'm not sure, but so the questions that we've not had answers to. So there's one is an observation. Someone is saying it would be good to see the DBI case studies from NHS24. Another question saying, what is the threshold for risk when people phone and express suicidal thoughts? I've interviewed people that have said they won't be honest about the level of risk because they don't want the issue to be escalated to emergency services. Hugely complex issue. So that's maybe one to take just now.
Yeah, that's a reasonable question. So as an unscheduled care service who are effectively working blind, we can't see the person, we don't have their case records. Sometimes we get to know our frequent callers, and we can gauge threshold for risk due to previous calls. However, our duty of care is always, to make sure that we intervene. If someone is actively telling us they're suicidal and they have plans or they don't have a support network, but that hence our psychosocial risk assessment is a full, robust assessment. We'll cover all areas. We'll see what support they have. Are they engaged with services? Do they have an appointment the next day? Are they on medication? And we very much go by, it is person-centred and what the person tells us. If they tell us that they don't have active plans to harm themselves or others, then we will try to work with them around what's best for them, because we understand that A&E police isn't the most helpful, and a lot of people that contact us do express suicidal thoughts, plans, but are able to tell you they don't have any intention of acting on them. The thoughts are frightening, but we have skilled practitioners within our services to work them through that and look at distraction techniques, coping strategies, even just to get them through to the next day so that they can engage back with their own services they're already engaged with, or they can call us back. We'll quite often say, okay, you're in charge of your care, you call us back within the hour. We've got mechanisms in place to make sure that it's person-centred. It's not one rule, you tell us this, we're going to phone police. We certainly don't work like that.
Okay, that's great. So another question is saying, are there any plans for NHS24 to be able to access patient records?
I would love that.
So I'm to giggle.
Cat's laughing. That's our aim. So there's 14 different care management systems across NHS Scotland. There's EMIS, there's Track Care. Every board does something different, and they're all fantastic systems, but none of them talk to each other. So yeah, we would hope so. We've had offers of like tests of change. Boards coming saying, "Do you want to see all our records?" We can't just do it for one. We have to have something for all 14. So, but on it, we've got our psychiatrist that works with us is looking at some of our complex callers, frequent callers. I know there's different terminology to services such as police, ambulance, and NHS24 unscheduled care. And what we've found is without knowing their names and details, they're calling us all, frequently. So looking at how we support those people rather than, They're frequently calling all services, you know, so they get the care that they need that's tailored to their conditions. But yeah, we would love that, but I guess we don't have the answer to accessing all records. All we have is a key information summary populated by the GP.
So I guess there's another question which is kind of the reverse of that one. Do the health boards have access to your full psychosocial history details?
So yes and no. Work in progress. We thought they did, but we're engaged with the Mental Health Review of Unscheduled Care pathway, the RUC pathways, a national programme, and we thought all records went down ad astra to the boards. Some were just getting a summary, some were getting the full psychosocial assessment. So we're in progress to fix that. Apparently it's a switch within boards they need to flick. Something technical like that, Gordon. So
another one of those gremlin things.
Yeah, but it's totally fixable, and that was our purpose, to share that full assessment, so the caller or the patient don't have to tell their story more than once. You know, there's a full assessment done real time.
So I think maybe final question, I think just now, is can information be added to KISS by GP if felt to be useful in frequent caller situations, such as care plans, etc.?
So yes, the answer is yes, definitely, absolutely. It's just the governance around that, you know. So if you put something on, it's on there until the GP takes it back off or updates it. So it's just making sure that if you ask the GP to put it on, make sure that it's kept up to date for us.
Yeah, I think that's great. I think that's all of the unanswered questions that we've had. I think you guys have been really good behind the scenes in answering questions in real time through the chat. That's good.
Is there anything you want to ask our Lisa from Breathing Space?
I'm just trying to work out this question here. Does Gordon know there is an angelic presence behind him? No, but I'm slightly terrified now. That's as if live webinars aren't bad enough. Sorry, I interrupted you, Lauren. You were saying something.
Yep, and I know we've got Kath, our senior nurse of mental health here, and Lisa from Breathing Space. So while we've got a captive audience, is there anything you'd like to ask about Breathing Space or Kath's role as senior nurse?
That's cool.
None.
Question at the end.
Another
there's
question.
Just one final question come in. What is your policy for triaging those with intoxication?
Yeah, we'll still engage for as far as we can. We wouldn't exclude a psychosocial assessment because you've been using alcohol or drugs. We'll still manage that as far as we can.
That's great. Thanks very much. If there were all of the questions that we've had, apart from the angelic presence one, will be compiled into a full kind of Q&A type session. So the answers that went on in real time will be included in that, and the answers that that we've had just now from the guys will be in there as well. Thanks very much, all three. That was really interesting work. I think at a future stage, potentially in phase 2 of this programme, it would be really good, I think, to explore something in a lot more detail round about that wraparound care for frequent attenders, because I know there's a number of areas are looking to develop some of those approaches, but that would be really good to hear more about that going forward. Okay.
Absolutely.
But
thanks
very much. Excellent. So we're now going to move on to Ishbel Brown, who's the nurse team leader for the mental health assessment unit in NHS Greater Glasgow and Clyde. Ishbel's going to give a presentation, and then we'll have a follow-on presentation from GAMH, and then Q&A. So if people are putting questions in the chat, could they maybe make it clear who it's for, if it's for Ishbel or for GAMH? Okay, so that's great. Ishbel, I'll hand over to you now.
Thank you, Gordon, and thank you for inviting us along today. The mental health assessment units are a relatively new service. We've been up and running for almost 3 years now, so I do know that people are interested to know what we do. So we have 2 mental health assessment units. I'll just abbreviate that to MHAU. It makes it much more simple. We have one in the north of the city and one in the south. We are a community service, but we're based within the both hospitals. So we cover the whole of GG&C. It's a huge geographical area. It covers from Cambuslang in the south all the way to Greenock. So it's not only geographically huge, but it also has a very dense population, and it encompasses all demographics. So can I have the next slide, please? Initially, we were set up to take the footfall from emergency departments during the lockdown. We have been given permanent status now, and our remit has widened. Initially, we were set up to provide a specialist service, and it's a nurse-led service, and we would provide an assessment, diagnose and management to patients who would ordinarily present to A&E or contact the police or the ambulance service in times of mental health crisis or acute distress. So in the 3 years that we've been running, that remit has widened, and we've broadened our referral pathways, and we're now one point of access 24/7, 365 days a year for emergency same-day face-to-face assessments, and that is a professional to professional referral pathway. So can I have the next slide, please? So we are a very small resource, and we need to be quite tight about our referrals. So they come from the emergency departments. There are 4 within our locality. So we have the Royal Infirmary, the Queen Elizabeth, the Royal Alexandra Hospital, and also Clyde Royal, as well as Police Scotland. These 2 remain our, primarily they are the biggest referrers to our service. We also accept referrals from the Transport Police, from the ambulance service. We do have a dedicated paramedic service attached to the units. I'll explain a bit about that later. We are open to all GP surgeries throughout Greater Glasgow and Clyde, and I'll explain about how that comes around shortly. In terms of the GPs, we also offer a service to the out-of-hours service, and as Lauren just explained, we are open to NHS24, the Mental Health Hub. We also have a reciprocal arrangement with the Compassionate Distress Response Service, who will give a presentation after me. That's an invaluable resource for us. So we will refer people who don't require a clinical response. As I say, it's reciprocal. So if they have any concerns following the referral, they can pass it back to us for advice or further assessment to get the person to the right service. We also accept referrals from the Emergency Social Work Service. Can I have the next slide, please? So we are open to everyone over the age of 18. In terms of youngsters aged 16 and 17, we are co-located in the Stob Hill site with Unscheduled Child and Adolescent Mental Health Service, who are also experiencing an acute crisis, whether it's regarding their mental health or in distress. So we'll pool and share resources with our colleagues from the CAM service in the Stob Hill site. From referrals from the emergency departments, that will be initiated by a telephone call in the first instance, and we'll negotiate what's the best, where it's best to facilitate the assessment. And we would expect a mental health triage and risk assessment tool to be uploaded to the portal so that we can access to that prior to the patient attending the unit. We try and ensure that we've got as much information as possible so that we can make a rounded decision after someone presents. So the person in all cases must be medically fit for transfer. And that would depend on a number of factors. We do have the capacity to carry out off-site assessments. For example, we can go down to emergency departments if there's a level of risk or mobility problems for someone at home. Invariably, though, the patient is generally asked to the unit themselves, and we can facilitate a taxi to make sure they get there safely, and we can also give them a taxi to make sure they get home just as safely. In terms of Consultant Connect, that is a dedicated mobile app, and it's available to all GPs within the Greater Glasgow and Clyde area. So they can contact us through that app, or they will contact us through the telephones within the units. They all have access to that number. So we'll have an initial discussion with a GP on whether somebody needs an emergency face-to-face assessment or whether another service would be more suitable. So we can offer advice, we can redirect referrals, and we'll also have a discussion with the GP about where, again, it's best placed to facilitate that referral. As we learned previously in the previous presentation, the Avers GP service and NHS24 have different digital information systems. So yeah, they don't connect at all. So we have a secure mailbox where referrals are sent to that, and that's monitored regularly throughout the day and night. In terms of Police Scotland and the ambulance service, they will initiate a referral through a telephone call, and we'll have the discussion. Sometimes things can be resolved over the phone, but invariably we would invite people to one of the units for a face-to-face assessment, and that would very much be dependent on where the person is located and where's best to offer that assessment, depending on clinical activity between the sites, because we do have the ability to pass work across, which we do quite frequently. Can I have the next slide, please? In terms of exclusion criteria, we just don't have the capacity to deal with any medical emergencies within the sites. We'll offer not complex treatment, but if someone requires treatment or, for example, ECG monitoring, they would need to remain within the emergency department and be fit for medical transfer before we invite them to the unit. And similarly with deliberate self-harm, particularly if they're requiring specialist onward referral for wounds and injuries. If the risk is identified as too high to transport safely, then whether that's through an absconsion risk, we will negotiate with our colleagues in liaison, particularly if an emergency department visit is required to facilitate that, to facilitate the assessment. We exclude those who have a score under 15 within the Glasgow coma scale, and if there's significant impairment due to alcohol, drugs consumption, which is a real tricky subject, because when is sober, we cannot exclude people who have taken substances. Obviously that increases people's risk, adds an extra layer onto our risk assessment, and as a society we use alcohol and other substances in terms of making us feel better, making us trying to induce happiness, to celebrate, to commiserate. So I mean, it's part and parcel of everyday life, and we take that into account. We also are fully aware that people use these substances to try and make themselves feel better, and we have to differentiate between what is a primary problem, whether it's drugs or alcohol, or whether it's a mental illness, and we can only do that following assessment. Can I have the next slide, please? So we are a really small resource. In each site we have 4 RMNs. As I say, it is a nurse-led service. We have a healthcare support worker whose part of their role is to meet and greet the patient. We generally have 1 MTL on, nurse team lead on, for each that will be responsible for both sites throughout their shift. And we have a dedicated admin worker at each site as well. If we require medical cover, at the moment it's covered by the duty doctor within the hospital sites, and we also have access to the consultant on call for more complex matters and advice. We do have a consultant psychiatry vacancy at the moment, and hopefully that will be uptaken in the time ahead. For the ambulance car, we have a dedicated paramedic service. So that is staffed with 1 RMN. Unfortunately, due to staffing shortages lately, the paramedic service will still run if we're unable to offer a nurse for that service. And they will carry out home visits, but they have the ability to come back to us, to give us a call, seek advice. Potentially, depending on circumstances, we can send a nurse out if necessary. And that service has been quite successful to date. So can I have the next slide, please? This is just to give you an idea of the referrals and the volume of work that we process. So this is for the past year. We're still collating the figures, obviously, for February and March, but it has been generally static over the last year and averaging out about 1,400 referrals a month. I don't know whether you can see that or not, but Levendale is slightly busier than Stob Hill. But as I say, we do have the capacity to share the workload across the sites, and that very much depends on clinical activity, staffing, and generally where the patient is located, where it's easier for them to attend the units. So unfortunately, I don't have any figures or breakdown for differential diagnosis. Certainly from an anecdotal point of view, the majority of people are voicing suicidality, and obviously that can be stemming from an underlying mental illness, so it can be the primary problem. So unfortunately, those figures aren't available at the moment. But this gives you a rough idea of, as I say, the volume of workload that we carry out on a month-to-month basis. So can I have the next slide, please? The challenges, well, is a new and developing service. We've ironed out challenges as they've occurred as best we can. But one of the difficulties that has remained with us is the fact that we have a crisis contact only. And that can be really quite difficult and challenging for clinicians. They have to be robust in their assessment skills. They have to be extremely confident in their processing of referral pathways onwards and proposed treatment. So we only have one opportunity to assess, diagnose and formulate a treatment plan for people. And once that's done, we have absolutely no control over the outcome once we've made that onward referral. Even in terms of information governance, we can't access anyone's notes unless we have a valid reason for doing so. So we take it in good faith that we have made the right decision and transferred someone to where they can best seek the advice, treatment and care that they need at that time. Like everywhere else just now, we have staffing deficits. We have a number of vacancies, both band 5 and 6 within the units at the moment. We rely heavily on bank staff, but we are very lucky that we've got a pool of nurses who have recently retired, who offer 1 or 2 shifts per week, and we've been very lucky in managing to have a full complement of staff using those very skilled professionals. It does remain a challenge though to staff the units, and as I say, it does have an impact on our ability to staff the ambulance car at times, but we're still there for the paramedics if they're operating alone. In terms of the digital systems, as we learned before in the previous presentation, they don't communicate at all. So that can be challenging for someone who is very well known to a service, where they have a proposed treatment plan. And I'm thinking of situations, for example, where someone is receiving psychological therapy, where it's taken a bit of time to get someone robust enough and stable enough to undertake that piece of work. And just by the very fact that they have entered that therapy can be destabilising at times, and people will seek assistance. So if they contact NHS24, unfortunately, we're not aware of that, and the MHAU generally acts as an information provider and a messenger, where we have provided an assessment to known patients who have contacted NHS24 and are then forwarded to ourselves. We'll make sure that their own teams are fully aware of that contact. But that's got the potential for conflicting care, and we are aware of that. The MHAU will offer an immediate response only. So people who contact services regularly invariably receive an inconsistent approach. Within the staffing at the MHAUs, we have two shifts. Day shift is from 8 in the morning to 8:30 at night, and night shift similarly is 7:30 to 8:30 in the morning. So obviously there's frequent changes of staff. Someone may come across, depending how often they are referred into us, they'll come across different clinicians every time they attend. And that can be extremely frustrating for patients who have to go over their history again and again. And as I say, it's challenging for the nursing staff who may be unfamiliar with someone who regularly presents. So, sorry, my phone was ringing there, it distracted me. Yeah, so yeah, the regular attenders could also previously have a relationship with some of the clinicians. We've only been open for coming up in 3 years, so people may have prior knowledge of the clinician beforehand, and obviously that can be a benefit, or it can also be negative at times, depending on the relationship. And then if you foster in the fact that someone has perhaps had to wait in ED for quite a significant time, they're fed up, they want to go home, they're tired. We have to factor in all these variables that can impact upon a relationship. And we, as I say, we only have one opportunity to get it right. So we we have to be quite skilled in reducing someone's distress, because we invariably come across patients when they're at their most vulnerable, they're at their most distressed, and it can be difficult trying to get together sufficient information at that point to facilitate onward referral to the best and most appropriate service for them. In terms of the environment, as I previously said, the units were set up very quickly at the start of the lockdown, so they're not really fit for purpose. We make the best of them. They're small. They are, particularly the Stob Hill site. And that's been escalated to senior management, who are fully aware of all the difficulties. As I say, they're not quite fit for purpose. We've had to do extensive risk assessments for both premises, and instigate a number of measures just to try and reduce risk for all parties. So that's a bit of a challenge. So in terms of meeting the challenges, can I have the next slide, please? Yeah, this is relatively new. Over the past few months, we have instigated and delivered a rolling training package. It's been delivered to all staff. We've been lucky enough to gain medical input from consultants and junior staff who are delivering dedicated training to all staff, and we record that and it's uploaded into our shared drive where those who aren't present on shift can access that at any time to upskill our nursing staff. We use that forum as well to invite other services along so that we can have greater awareness of what's out in the community and in inpatient basis, so that we're getting the referrals to the right place following assessment. So, for example, we've had the adult eating disorders team in, we've had the perinatal service in, we've had the crisis outreach service in to try and get our addiction knowledge up to speed and so on. So that's a good avenue for working and networking where we can learn about other services. So we deliver that on a Wednesday morning. We have dedicated time for our teaching programme. We also, through the avenue of supervision and within the units, we encourage individual learning and for people to pursue their own interests, obviously providing that it benefits the service, and we encourage that learning to be cascaded throughout the team. It hasn't happened so far, but in the time ahead we would be hoping that should someone undertake an area of interest, that they will get involved in the Wednesday morning, deliver a presentation, and it'll be up for discussion throughout the wider team. The next area that I was going to discuss is an MBT pilot, and I'm really excited about this. It's very unique to our unit. I'm thankful to Dr. Williams, who has allowed staff from her own team to really meet the needs of our service, because we have had 6 nurses who have undertaken a period of theory studying. They've had a couple of days off to complete that, and we've secured the services of a nurse consultant who will be meeting with those nurses very, very soon. And that's for the purpose of the nurse consultant being involved within assessments, and that'll be in terms of a coaching role for her. So she'll work individually with the nurses who've undergone the theory training, and I'm keeping my fingers crossed that it'll be when patients actually come into the unit, because in unscheduled care we can't predict from 1 minute to the next minute what's going to happen. So fingers crossed that there will be people up for assessment during those periods when we've arranged that. Similarly, with the DBT training, we've had a couple of nurses, one from each unit, who have undergone a couple of days in the theory of DBT. And I believe that in the time ahead, they will be attending practical workshops. And hopefully with those 2 pilots ongoing, they will be audited to see how successful they are in terms of the model being used within the units, and whether that would be rolled out to further staff in the future, so that we can meet the needs of the population that we serve. We do foster collaborative working with other services. We'll regularly go to meetings, both inpatient and in community services. We get invited to CPAs. It's very helpful if the generic teams do have management plans, but we need them to be up to date. So it's helpful to actually be at the meetings such as a CPA forum, so that we can gather as much information as we can for example, if someone is quite a regular attender at the MHAUs. We also have meetings with police liaison, and yeah, that's to be encouraged in the time ahead to get our services widely known, and to have inroads to other services so that we can have collaborative working across the board. So I think the next slide is my last one. If you could. Yeah, further developments. We did have an advanced nurse practitioner within the service, but unfortunately they left for a promoted post. So that role is still on the agenda. It hasn't been filled as yet, but their role was to help out with the task that a duty doctor would undertake. So they would, in terms of an informal admission, they would do the clerk in, and they would also have a role in prescribing medication. Within the units, we do have, it's called patient-directed guidance, and the nursing staff, although we're not nurse prescribers, we do have a limited capacity to offer patients a take-home box of limited medications, small doses of such things as diazepam and sopiglone, without having to invoke the services of the medical staff or a nurse prescriber, should we get one in the future. And that's also available to the crisis team. So that's a specific role that is unique to us. And in terms of working with the crisis teams, they were involved in an unscheduled care review, and we have got close links with them. We have regular meetings between the nurse team leads from both services to foster closer ties with them. We promote joint working, specifically at times of the day when the crisis teams would be closing. They'll pass work to us. We'll offer joint visits between the services depending on capacity between the teams. We'll seek information from each other, and we'll pool and share resources. For example, the crisis team do use the interview rooms at times within the units, which, as I say, is a very small resource. We only have 2 within each unit, and we'll negotiate and facilitate the crisis team colleagues using those interview rooms. The crisis outreach service, that's a service which is allied to the addiction service. So they were initially set up to work with people with non-fatal overdoses who had a problem with substance misuse. And like our own service, they have also widened their remit. They will also deal with people in an acute crisis who have problematic relationships with alcohol. And they've been an invaluable resource, particularly as they're co-located within the Stop Hill site. So we have a reciprocal arrangement with them as well. So we'll pass referrals between ourselves, depending on what the primary difficulty is that the person is presenting with at that point, whether it's difficulties related to addictions or whether it's a mental health problem. So they've also been very helpful in providing training for us. We've had withdrawal training so that we can recognise the signs and be up to speed in terms of what the addiction services provide. CDRS have already spoken about our reciprocal arrangement with them, and obviously as our service is new, it's still evolving and constantly being evaluated and under scrutiny. So in the time ahead, who knows what will happen. We're very dynamic. We're open to feedback. For example, we have a patient leaflet that we handout, and that is a QR code. So we encourage our patients to use their mobile to open that up and give us feedback, which is sent to senior management. So who knows what's going to develop in the time ahead. So thank you for listening. I'll give you back to Gordon.
Thanks very much, Ashbel. That was fantastically interesting. We're running a wee bit over just now, so I'm going to very quickly hand over to Rena, Susan and Chrissy from GAMH, who are going to talk about the Compassionate Distress Response Service. Thanks.
Thank you. To start, Gordon, yes?
Yep, absolutely.
Hi, so I don't know if I need to. So thank you for the invitation. We're a non-clinical provider in an unscheduled and primary care landscape. Hopefully the video link sent prior to the webinar will give you some context where we fit into unscheduled support. I'll provide some background to CDRS. My colleague Chrissy will provide an overview of a case study, and Susan, one of the project leads, will highlight our emphasis on staff well-being. The background to CDRS. Next slide, please. Sorry, Gordon. The background to CDRS was the multi-agency collaborative. There were two parts to this exploratory piece of work. The first part was that not all statutory services were saying that not all distress requires a medical or clinical intervention. The second part was service user consultation, which emphasised the need for compassionate and immediate distress response. Post the multi-agency collaborative, Glasgow City HSCP commissioned GAMH to deliver an alternative distress response, which is now the Compassionate Distress Response Service, CDRS for short. CDRS was set up between May and September 2020, so we've not been operating for that long. CDRS is now aligning with the Scottish Government further rollout of DBI to be delivered in all 24 local authorities by 2024. Next slide, please. CDRS, Glasgow City CDRS has 3 distinct distress response pathways. The pathway for unscheduled care, or out-of-hour service, takes referrals from the mental health assessment units at Levendale and Stobhill, psych liaison, the mental health triage car, emergency departments at Queen Elizabeth, Glasgow Royal Infirmary, out-of-hours CPN, out-of-hours GPs, social work standby, police and ambulance. For our out-of-hours service, the individual can be from anywhere in the UK as long as they're in Glasgow at the time of distress. Our out-of-hours service has a 1-hour response time from point of referral. It's open 7 nights a week, including Christmas and New Year. Our primary care service is for GPs and their multidisciplinary teams. Our young people service takes referrals from the two existing pathways, but was specifically set up for schools, CAMHS, further education and higher education. Both our primary care and young people are daytime services and has a 24-hour response time. We've also got a test of change at the moment in East Dunbartonshire for young people. Most of the support is telephone support, but we do have some face-to-face support and some outreach as well, if that's more appropriate. Face-to-face support seems to be more popular with the younger people. Next slide, please. So referral criteria to CDRS, you have to be 16 plus. It's a profession-to-profession referral only. There are 2 reasons for no self-referrals. We need to get as much accurate information prior to making contact so that we can manage risk, so that we can be prepared, and so that there's kind of limited repetition. Secondly, we also want to manage our response time, which is 1 hour or 24 hours. So we couldn't manage that with incoming calls. Individuals have to have consented and have capacity to engage. If the individual is under the influence, we'll ask to call back at a time that's more suitable. So there's lack of conditionality apart from immediate risk. For example, having a suicide plan. If the individual is at immediate risk, then they need statutory intervention. If the risk is disclosed during the intervention, we'll escalate quickly for a police welfare check or an agreed short circuit back to the mental health assessment unit. With GBI alignment, GPs will be notified regardless of whether whether the individual engages or not. To make a referral, it's simple. It's either phone, email, or almost all the GPs tend to use Sky Gateway. Next slide, please. Key features of CDRS: we respond quickly to in-the-moment emotional distress. Support can be provided for up to 1 month. It can be longer. We can look at it on a case-by-case basis. We provide a range of self-management and positive coping strategies that can help in the present and hopefully help in the future as well. We'll also do onward signposting. GAMH has over 40 years experience of community support, so we're aware of the local networks and supports available to people. Support plans are developed in partnership with the individual. Making meaningful connections with the individual is crucial to keep them engaged, but also to keep them away from GPs and unscheduled care if that's not needed. We can also access three-way interpreting and translation of resources if required. This has been quite successful with our asylum-seeking communities. Although we're non-clinical, our staff are very skilled and we can access training quickly via our in-house GAMH training and development department. Risks are managed safely. This includes safety planning. This is important at the start and throughout the intervention. We have a quick and efficient escalation process. On average, it's between 1% and 2% escalation, meaning that distress is managed effectively within CDRS. We've seen a noticeable number of men, young people, transgender representation, more so referred to out of our service, coming in crises. There's almost half the referrals via unscheduled care are men, whilst only 1/3 of men are coming via the GP pathway. Next slide, please. This graph just shows where we're getting the majority of our referrals from. From unscheduled care, mental health assessment units make up almost 70% of our referrals. Referrals from unscheduled care, again, it's a 1-hour response time, and we've met that 100% of the time. From our primary care pathway, total GPs referred is 636 at the last count. GP referrals to CDRS is increasing day by day. It's a 24-hour response time for primary care, and that's been met 99% of the time. There is no waiting time for CDRS. Contact is made quickly, as quickly as possible. Next slide, please. Reasons for referrals. I'll focus again on unscheduled care referrals. The main presentations are suicidal ideation, suicidal behaviour, anxiety and stress. During the pandemic, we noticed quite a bit of distress related to loneliness and isolation. Post-pandemic, we're noticing distress related to money, debt, work, relationship, bereavement and health-related issues. So we sometimes see changing patterns of distress presentations over time. There's a lot of data in CDRS relating to age, gender, demographics, even the number of distress presentations per individual, but we've only got 15 minutes for this presentation. Next slide, please. So I'll kind of look at the presentations of concern, particularly coming via unscheduled care. Suicidal ideation, suicidal behaviour, even methods described to harm self are quite concerning. Also concerning are the number of impulsive and deliberate overdose, non-fatal injuries, distress related to childhood trauma, sexual abuse, sexual assault, addictions and homelessness. Re-referrals to CDRS is very low. However, individuals will be re-referred if unscheduled care services has also seen the individual on multiple occasions. The individual has a history of mental health individual has a history of suicidal behaviour. They've had maybe long-term engagement with mental health services, or they've been described as or have attracted a diagnosis of EUPD. It's usually with this type of more complex presentation that a more statutory, clinical or medical intervention is required. However, even in such cases, compassion and time to listen from CDRS has helped in the short term. Next slide, please. We've had a very detailed external evaluation of CDRS. From a sample of over 5,000 referrals analysed and 178 interviews, the evaluation has highlighted the speed of our response, the 1 hour during unscheduled, during out of hours, and the 24 hours during the day. The frequency and duration of contacts made, on average, is 87 minutes per contact, particularly so for individuals coming via unscheduled care. Our positive attitude towards referrals is person-centred, and usually it's one member of staff providing that support over that period. Our lack of conditionality, use of alcohol and drugs is not a barrier to support, as can be for many services. The evaluation also pointed to the complexity of referrals via unscheduled care were more intense than anticipated for a low-level distress response service. You can see that distress associated with general risk of suicide, substance abuse, self-harm were much higher via the unscheduled care pathway rather than the GP pathway. Next slide, please. How we respond makes a big difference. In CDRS, people had time to tell their story. People reported being treated with compassion and kindness. They felt held. Comments such as, "They had my back, it was sticky care," were prevalent throughout the evaluation and is common from service users on an ongoing basis. I'll now pass to Chrissy, who will provide an overview of a case study. Thank you.
Hi, I'm Chrissy McCaig. I'm a coordinator in the out of hours service. I'm not going to labour the case too much because I'd like to get to the questions. This was a young woman referred by the Mental Health Assessment Unit with fairly distressing and intense thoughts of harming herself and her mother with a knife at the time of referral. Sorry, could we get the next slide? Sorry, I thought it had moved already. So again, a young woman with distressing and intense thoughts of harming herself and her mother with a knife at the time of the actual referral. There was a fairly complex history of childhood sexual abuse, difficult and traumatic childhood experiences, crippling anxiety, body issues with a history of anorexia, and ongoing bereavement and caring issues. Next slide, please. Jenny was exceptionally keen to develop positive coping strategies and benefited from having the space to openly discuss her self-harm in a safe, non-judgmental environment. She responded positively to distraction resources and relaxation and breathing, also mindfulness, but especially 5-4-3-2-1 grounding and the soothing box resource. She was also particularly grateful to engage with self-harm resources. By the time the 4-week service ended, she was successfully re-engaged with her local CMHT and begun to attend the STEPS Cognitive Behavioural Therapy programme. Small achievable goals were key to her support, which allowed her to enjoy previous interests, free from a fight or flight response, which she was managing successfully at the end of the support period. And I'll pass you to Susan. Next slide, please.
Thank you. Hi there, my name's Susan Rendell. So I am one of the project leads from the INNERS Compassionate Distress Response Service. I am just going to, I believe that there should be probably a lot more about what I'm going to talk about next, but I am wanting to make it brief. I'm just looking at the timings here. The fact that we would like to create a culture and environment of support for the individuals that work within our service. All of the responders that work within the Compassionate Distress Response Service, whether it's younger person services or in ours or out of ours, our teams are listening to probably what is secondary trauma. So it's really important that what we do is we encourage our staff members to have time and space and compassion for themselves. So how do we do this? We do it through self-care. We encourage individuals to use the techniques that we use for supporting individuals on ourselves. For example, muscle relaxation exercises or journaling, or maybe just even taking a short break from the work environment. We are very close to Glasgow Green, so we encourage people to get out and actually get fresh air and take breaks. And sometimes what we even do is try where we possibly can to encourage people to go out for walks. Team debriefs are really important. We normally have them towards the end of the week, and that might be a session for half an hour where everybody can sit and decompress and talk through what we have found difficult or challenging with our colleagues. The debriefs can be both informal and they can be formal. Group supervision, which we invite somebody who is external to the organisation to come in and facilitate a group session with the teams where they've got a safe space to talk about the difficulty of the calls they might be experiencing, or even to talk through difficult situations. Support and supervision tends to be much more, I would say, formal, but it's about giving the individual time to reflect on the practice, and be able to say how they think and feel in a safe space. Staff skill set, we've touched on that around in Rena's presentation, where we talk about the diversity and the range of skill set that each individual responder will get, and feeling valued. And I think that's a really important one to finish on. Recognition and sharing good practice in the team. When we see someone progress and develop through positive strategies that we've supported, what we like to talk about is the successes for people and how it's worked for them. We also talk about when it doesn't work, what maybe went wrong, what happened, and how can we do better. We do believe in the Compassionate Distress Response Service that whatever we do, we can always do better, and we always learn from this. I'd like to thank you very much indeed for your time and inviting us along today. Thank you.
Thanks very much, guys. We're quite a bit over time, but what I was thinking was we've had lots of information on lots of slides, so we'll still try and have a couple of questions just now for both yourselves and for Ishbel. Since you're on camera just now, I think there were a couple of questions asked that have been answered, but there was another question come in. So Fiona Maguire from NHS5 was asking, is the service permanently funded, or do you require to apply for funding annually? Is the funding split between Charity Health HSCP?
I think the background noise might be coming from me. There's some work going outside. On the, can you hear that? So on slide, on the second slide, we do have a funding stream. Our out-of-hours service is funded by the Scottish Government 10-year mental health strategy, which is Action 15. Our primary care funding is funded through PSIP, and our young people pathway is funded from Children and Young People Community Mental Health and Supports Services Framework. So we do have different funding streams coming into CDRS to make up the whole kind of like the different pathways.
That's great, thank you. I think we'll maybe a couple of questions to Ishbel, because there were a ton of questions for Ishbel, 17. But we could. All of the questions will be answered. They'll all go into the mail out, so everybody's question will be answered. But I think we're about 10-12 minutes over just now. So right, one of the questions here, Ishbel, is that you mentioned the paramedic and RMN car has been successful. The person is asking, I was wondering what successful means in relation to that part of the service.
Right. I think the paramedic service is much busier at night time. I'm primarily day shift. They have many more call-outs during the night than they have during the day. Senior management would be able to give you the figures and so on, but anecdotally from the nursing staff, you know, it's a quick pathway for patients. Generally, when someone phones NHS24, for example, they have to get through the channel. An ambulance would be called, and then the paramedic service would take the person to A&E. The paramedics now have direct access to us via the call comes from the control room. So as I say, essentially it is a paramedic service, and also they will field all the calls to see if they can take work off the generic paramedic service. Unfortunately, I don't have stats or figures. As I say, senior management would be better equipped to be able to give you the data on that, really from an anecdotal sense that I had included that in the slides.
Okay, that's great. We're going to move on to the next presentation. Look, as I said, every one of the questions will be answered, guys, but there's so much for us to talk about. Great examples of really good work that's being done. So just thanks, Ishbel, and thanks the GAMH crew for your presentations. So we're now going to move over to Professor Andrew Gumley, who's going to speak about the remote approaches to psychosocial intervention. Over to you, Andrew. You're on mute, Andrew.
Brilliant start. Gordon, thank you very much indeed for the opportunity to join the webinar today and to talk about the RAPID trial, which is Remote Approaches to Intervention Delivery. It's a trial that's funded by the National Institute for Health Research. It covers the UK. Next slide. It's a large-scale trial that is across the UK and includes centres in London, in Oxford, in Manchester, and in Glasgow. Next slide. And our team is here, based in Glasgow. We're actually based within the Crisis Intervention Services in NHS GD&C. So we're based in the North East and the South Crisis Intervention Services. And I have to say a really fascinating and important part of learning for this particular study has been embedding such a large-scale trial in Glasgow, but embedding it properly within services as opposed to trying to run it from the university. So all of our staff are employed by the NHS and are based in the crisis intervention services. So I want to just make sure I thank the services for their support to this study. Next slide, please. So RAPID is a clinical trial. I'll come into the details of the clinical trial, but it's based on its aim is to reduce on psychiatric admission and in particular unscheduled care. And the way in which we aim to do this is by testing 3 separate psychosocial interventions that are remotely delivered. And all of these interventions aim to target suicidal thinking and behaviour. So next slide, please. So it's a large scale, very large scale. So our aim is across the UK to recruit and randomise 1,250 people. So it's probably the largest trial I've been involved with in the NHS in my career. It's a multi-arm trial in that we're testing different therapies in parallel, and it's a multi-stage trial in that after around 18 months we have an interim analysis, and we will drop any interventions that are not showing any signals on outcome. And this is a design that's taken from trials that have been conducted in cancer care services, where there's a need to properly embed clinical trials into routine care. Our aim is to test and compare. Our aim is to compare 3 remotely delivered psychosocial interventions. The first is a peer support intervention called Prevail. The second is a self-management intervention called SafeTel. And then the third is a digital intervention called Brighter Side. I'll talk about these in more detail in the following slides. All of these interventions are tested in combination with treatment as usual, whatever that is, and is compared to treatment as usual. So when people when people give informed consent to enter the study, they're randomized to one of these 4 conditions. Our aim is our hypothesis is to reduce psychiatric admissions over 6 months, specifically for people who have a serious mental health problem and who are in crisis care and are experiencing suicidality. We don't aim to replace or replicate existing interventions, but very much try and run alongside interventions that are being carried out in routine care. Next slide, please. So as I said, the service users who are eligible for this study are people who are experiencing a serious mental health problem and are at increased risk of psychiatric hospital admission due to suicidal thinking and behaviour. So our eligibility are the people are aged 16 and above, that they're currently receiving care from a crisis care team or a intensive home-based treatment team in the last 14 days, that they're also receiving care from a secondary mental health service, that in the last month they've experienced suicidal ideation. And our criteria for serious mental health problems is quite broad. So this includes diagnostic labels such as schizophrenia or bipolar disorder, EUPD or major depressive disorder. And of course, the people are given the opportunity for informed consent. Just to say because our Brighter Side app is only available in English at the moment, we're only able to randomise people who have sufficient command of English to take advantage of that app should they be randomised to it. And also we do not exclude people who have ongoing drug or alcohol problems, but where there's a primary diagnosis of a drug or alcohol dependence disorder, we would not take those individuals into the trial. And we have a number of other exclusion criteria that are pragmatic to do with being able to engage with the intervention or being able to use the intervention. So for example, if people have visual impairment that's severe enough to prevent engagement with our Brighter Side app. And that's a requirement that from our regulators. Next slide, please. I wanted to really take the opportunity to describe some of the interventions that we're testing in this trial. So we're at the moment, the trial started in August 2022. The first year of running the trial up until June 2023 is what's called an internal pilot. And during that internal pilot, we need to be able to demonstrate that we can deliver the interventions that we're planning to test, that we can recruit to the trial and we can embed the trial into local services. So we're just coming up to the end of our pilot period, and so far our recruitment has been very successful and we've been successful in implementing these interventions. So the first intervention is Prevail. It's delivered by our peer support worker, and it's a peer-led intervention that's delivered over 12 weekly sessions, and it covers an initial phase of getting to know the person, transforming into kind of getting people more actively involved, and then having an ending and consolidation phase. The Prevail adheres to key principles of peer support, so things like reciprocity and mutuality, validating experiential knowledge and expertise, having a focus on strengths and having a focus on sharing. The peer support workers sharing their own recovery story. But also the peer support worker utilises techniques from CBT and motivational interviewing, as well as reinforcing skills that participants have been learning in other therapies that they've been accessing. So for example, DBT or in Glasgow Steps. And the aim is very much to empower participants to come to their own decisions about what works well for them, identifying and emphasising their strengths and setting and celebrating goals for recovery. Next slide, please. And just to give a bit more flavour of what a session would look like, so there's an initial sort of general support phase to the session where our peer support workers will check in, we'll check in how things have been over the last week. We'll check in around risk-informed work. We'll identify any kind of risk assessment, and also we'll report any kind of risk factors that emerge during a particular session. There's a technique that's called ILSM, which is inviting, learning, sharing, and motivating, which is really around choosing a kind of topic for that particular session, inviting the person to share their experience, working in reciprocity with the peer support worker, sort of learning and sharing about that experience, and then using that to motivate towards setting goals, and then a kind of wrap up in the last 10 minutes. Peer support workers receive a combination of both regular individual supervision and also group supervision across with other peer support workers in the UK. Next slide. So our kind of second intervention is an intervention called SafeTel. This has been previously piloted in Glasgow. It was embedded in A&E services. This is a brief, evidence-based, again, telephone-delivered safety planning intervention. It's implemented by our assistant psychologist, and it has a focus on suicide prevention strategies, including coping skills, problem solving, referrals to external sources, and motivating people to engage with, utilize, and utilize their safety plan. So in the initial session of SafeTel, the focus is very much on collaboratively developing and completing a safety plan that includes a number of elements, including early warning signs, coping strategies, having a kind of sense of who the social network is and who the key contacts are for social support, who key contacts are in terms of health professionals, and also minimizing access to lethal means. And then over the 12 sessions, the SafeTel very much focuses on reinforcing and updating that safety plan. Next slide, please. And again, it's a 12-week intervention that includes 3 overall components. One is, within each session, then there's a suicide risk assessment and mood check. There's a review of the safety plan and any adjustments, and then engaging with people to support their engagement with broader treatment with the safety plan, but also with broader treatment. And it's usually calls last up to around 60 minutes. And at each session, participants' experiences in the last week are kind of utilised to update and modify the safety plan. Next slide, please. And the third intervention, the third arm of the trial, is Brighter Side. And Brighter Side was developed in Australia by the Black Dog Institute. It was tested in other populations, not people with serious mental health problems, but in a number of RCTs that showed that Brighter Side was successful in reducing suicidal ideation. Because the app was developed in an Australian context, we also had to make some significant modifications to the app, just in terms of making it accessible in the UK and in a Scottish context as well, re-scripting a lot of the exercises, and also making the exercises and techniques more sort of culturally appropriate. So, for example, given the app was developed in Australia, suggestions of going down to the beach, being mindful, things like going down to the beach for a walk aren't always that great, don't always translate very well in a Glasgow context. So we have a sort of our one of our peer researchers in my team, Susie Sirrett, revoiced a lot of the content for the app to make it applicable in a UK context. And for that reason, the app is we can't make the app publicly available yet because it's under testing, and it's also regulated by the Medicines and Healthcare Authority. It's an interactive self-help app. It contains 5 modules which are around understanding your thoughts, preventing a crisis, understanding and navigating emotions, navigating thoughts, and then planning for the future. And each of these components, each of these modules has 4 components, sort of a bit of theory or an overview of the content, a weekly assignment, 2 to 3 exercises, and then options for additional exercises. And participants are encouraged to complete a module each week and spend around 30 days using the Brighter Side app. And our assistant psychologist helps install the app on the phone. And in order, I should have said at the beginning, in order to avoid issues around digital exclusion, all participants in our study are given a mobile phone and are given a data package that they can use to participate in the trial more generally, and also, if randomized to Brighter Side, use Brighter Side as well. Next slide, please. I'd also like to mention, just very quickly, our Lived Experience Advisory Forum that we're putting together. So this is a forum of people with lived experience that will meet 4 times a year, based in Glasgow. People are paid for their time, and very much the Lived Experience Forum will inform our protocol, our procedures, our recruitment, the delivery of our interventions, our progress and results. And this is something that we've used. This is something that has been hugely beneficial in other studies that we've run, where we've had the opportunity to really reach in and seek the advice and experience of people with lived experience to help us conduct the study and help us learn from their experience. Next slide, please. And these are some key contacts, but please feel free to make contact with me if you have any questions about the study. There is a really nice question there about changing the randomization for those with poor vision. And yeah, we can't do that according to when in a randomized controlled trial, because once somebody's randomized, they need to stay within an arm. So it's a restrictive aspect of that. But it's a really good question, Francis. Thank you very much, Gordon.
Thanks very much, Andrew. That sounds like hugely interesting work. As mentioned before, we're running a bit behind, so I'm going to go straight over to Nicola, Naven and Mathew Morrison, who are going to speak about mental health and crisis within GGC. I think what we'll do immediately after that is do some of our evaluation polls and then some questions, so we'll rejig the order of that. But I'm taking up time by talking, so I'll stop talking. Over to you guys.
Thanks very much, Gordon. Thanks for having us. So I'm Nicola Naven. I'm a general adult consultant in Glasgow, and my colleague is Matt Morrison, who's a liaison consultant in the GRI. And Matt will speak about capacity just after I speak a bit about crisis. Next slide, please. So one definition of crisis is a clear precipitating event causing acute anxiety and emotional suffering, an acute reduction in motivation and problem-solving ability, and an increase in help-seeking behaviour. So crises within BPD are often precipitated by interpersonal or social factors, and the duration is usually short. So it would be days, hours or days, rather than weeks or months. The primary aim for staff is to help the person return to their usual level of functioning as soon as possible. And during crisis, or a crisis presentation, staff should keep their goals simple and focused on the present and immediate future. Next slide, please. So there are some principles of responding to a crisis. Firstly, having already developed a shared crisis plan or self-management plan can be incredibly helpful. And any person with a diagnosis of BPD should be encouraged to work collaboratively with staff to develop this. And this can help to highlight the strengths, responsibilities of the individual. And it also includes helpful things like crisis indicators, specific actions people can take to help themselves, what others can do to help, what's not helpful in a crisis, and some useful contacts. and this document remains the property of the individual for them to refer to when necessary. Next slide, please. So another important principle when responding in a crisis is to remember empathy and validation. So it's very helpful if the clinician can remain calm, supportive, not judgmental, not to express shock or anger at what's been spoken about, not to focus on historical issues, historical trauma, or to plan too far in the future. It's really to focus on the here and now, and really to express empathy and concern. It's helpful if the person can explain the roles of all the staff involved, conduct a risk assessment, which I'll just touch on risk assessment, and then to ensure there's some follow-up planned and that the usual team who look after the patient are aware that they have presented in crisis. So active listening, patience, awareness of body language, and respecting the patient's narrative are all important. And these things in themselves can sometimes have an immediate calming effect. Next slide, please. The next very important part of the response is a risk assessment. So this is really a whole talk in itself, and I'll just touch on it briefly. And I'll just summarise what I tend to say to patients and patients with BPD and their families when they present in crisis or when it comes to discussing admission. So I usually explain that the risks and benefits of hospital admission for people with BPD in crisis are well documented, that there's almost no evidence for prolonged hospital admission, and that brief crisis admissions can have a role, but in order to be effective, there must be a clear discharge date set, usually within 48 to 72 hours of coming into hospital, and that the majority of the effective interventions that we have are delivered within the community. Next slide, please. So there's a very helpful model which has been described by Dan Warrender, and this considers the short and long-term risks and benefits of tolerating risk versus containing risk. So when someone with BPD presents in a crisis, it might be the case that they're seeking an external source to contain the risk or to really provide regulation for a dysregulated mental state at that time. However, some interventions that aim to contain the risk could have negative consequences because that doesn't really promote self-regulation if the hospital is providing the regulation. And containing the risk would often include admission to hospital, sometimes using the Mental Health Act, and sometimes using constant observations. So that might keep the patient safe in the short term, but it could lead to dependence on the hospital for regulation in the long term. And NICE guidance also states that admitting a patient in crisis might reinforce the belief that they can't keep themselves safe. So in contrast to this, tolerating risk and promoting community resources and the self-management plan, it can have positive outcomes, such as increased autonomy, using the least restrictive options. And it's also known that there is a dearth of evidence on hospital admission being a successful intervention in suicide prevention. So there are some negative consequences of tolerating risk, and that's that the patient may feel as if they haven't been listened to, and they may feel the need to demonstrate their distress if they feel that their suffering isn't been taken seriously, and this could sometimes be a further self-harm attempt or a further suicide attempt. So I will just finish up my section with a very helpful quote from the Mental Welfare Commission, which reminds us that it's not acceptable to use the important principle of patients taking personal responsibility for the recovery. Sorry, next slide, please, I should have said. For the taking personal responsibility for the recovery as a justification for declining hospital admission when patients are not offered ongoing support in another setting to promote that recovery. So in other words, it's not acceptable to say, you need to self-manage, there's nothing we can do. It's very important to support and validate patients with BPD in a crisis and to give them a sense of hope for the recovery and offer an alternative to hospital admission. So I will just hand over to Matt now. Thank you.
Thanks. So,
sorry, I'll just mute.
So if we can just move on to the next slide, please. So when we were asked to speak about this was we were considering our own capacity guidance within the borderline personality disorder pathway within GGNC. And as a liaison psychiatrist, almost every day we are asked for opinions on capacity, often for patients who are presenting in crisis and whether they can refuse treatment. But a lot of our work can also be in reviewing patients where decisions have been made that a patient has quote unquote kind of full capacity in the midst of a crisis presentation. And much of my focus here will be on borderline personality disorder, and that is because such a huge number of our patients with diagnoses of BPD will often experience quite marked inconsistencies in their care while they present in crisis, and there are often also complex queries around capacity and treatment. Much of what's on this slide will be familiar to many, and I suppose the kind of thinking about kind of what is capacity, the kind of the more simple kind of definition is, I suppose, the ability to use and understand information to make a decision and to communicate any decision made. And a person may lack capacity if their mind was impaired or disturbed in some way, which meant they were unable to make a decision at that time. And again, I suppose when I'm thinking about my experience as a liaison psychiatrist, I wanted to focus on the potential pitfalls around capacity and crisis presentations based on what we see regularly. I wanted to focus on this was also how we can provide support and education around capacity assessments for those who may be less familiar with how some of the more subtle deficits in decision making can also present. So I suppose one of the things I wanted to highlight was that often in crisis situations when patients are presenting in the general hospital or other settings, well, mainly the general hospital, I suppose, there may be a lack of cumulative experience in assessing patients in crisis, and it may then lead to clinicians' own assessments being impacted by a combination of their own lack of experience in these scenarios, but also a lack of recognition about the types of emotions that may be aroused in clinicians by patients who are presenting with BPD regularly. And 9 times out of 10, when I'm in the hospital and when I'm asking junior medical staff about their capacity assessments, there's often a clear focus on retention of information. So when we're thinking about the meaning of incapability, there's often a focus on the communication and the retention of memory around decisions. They can tell me that the patient can remember the risks and benefits of the intervention, the risks of refusal. They can repeat the information back 15 minutes later, and they know that they could come to harm or die. But because they can do all of that, they have the capacity to refuse information. And that's often how less experienced kind of medical staff will have those conversations with me. And sometimes the very repetition of that information in itself is often used as evidence of an absence of impairment. And there's often very little consideration given to the acting part and the kind of making decisions part of capacity assessment. And that can also sometimes be used, as Nicola touched on, as well as a means of autonomy, patient autonomy sometimes being used as an argument to not provide treatment to someone who may very well need it. Next slide, please. So again, all of this will be very familiar to most, but it was really just to highlight that, I suppose, especially in mental health circles, the conversations around capacity can often be in the context of deprivation of liberty frameworks. So adults with incapacity, guardianships, Mental Health Act work. And sometimes I often come across kind of conversations with staff who kind of feel that they can't assess capacity because they can't complete the paperwork. And within general hospital MDTs, you know, staff often don't consider that they are making determinations around capacity day in, day out, evidence of impairments, evidence of function, and evidence of maladaptive means of eliciting care. But without, again, that cumulative experience of how crisis presentations may present in different environments, sometimes it could be challenging for staff within the general hospital to formulate those kind of decisions, and it's important that, I suppose, we're able to kind of, again, guide and support them. A key part of our role is obviously to advocate for patients, and part of this, as I said, is supporting and educating clinicians in developing their understanding of BPD, of crisis and capacity. And when we start to assist in this development of understanding, we start to see two shifts. Next slide, please. So the first is a shift in consistency and standards of care, respect for patients who are presenting in crisis, and improving engagement in patients who are presenting in crisis. The second is a shift away from what we see here, which is that with minimal kind of cumulative experience, often people will consider incapacity as basically unconscious, refusing treatment on the basis that the devil is telling them not to accept it, something very, very textbook like that, or an inability to recall any information. But as we start to support staff in letting them understand how crisis presentations can impair capacity, staff will eventually start to see that, you know, as you hear, you know, incapacity can take all, you know, it comes in all different forms, all different shapes and sizes, and it's beyond just a simple retention of information. This is even more important, I suppose, since 2020, because as health boards in Glasgow specifically have developed the MHAUs, which have a very clear role and purpose and are very much required in how we assess patients now, one of the kind of side effects has been that probably around 90% of patients have moved from A&E departments to off-site MHAUs, so thinking about Glasgow in particular. So there's been a loss of this cumulative and experiential learning that acute care staff within the ED sites, for example, have had access to. So there's an even greater onus on us to kind of support and educate staff in how they think about incapacity, again, in patients presenting in crisis. We need to support staff outside of mental health environments and understanding that, you know, extreme and relatively sustained emotional dysregulation in patients with EUPD in the aftermath of a significant stress, spiraling suicidal ideation and intent can sometimes actually impair their capacity to be involved in considered decision making, especially when it involves treatment, which could be life-saving. Next slide, please. I'll quickly just touch on this. It's an excerpt from Capacity, Consent and Compulsion for Treatment for young people with BPD from the Mental Welfare Commission. It was a case many years ago involving a Jehovah's Witness who was pregnant in a car accident and refused a blood transfusion. But essentially, I suppose the take-home message here was that the kind of judgment was that their doctors need to consider whether, and I suppose all of us need to consider whether capacity that is present is commensurate with the seriousness of the decisions that are being taken. In other words, it's legitimate to look for a higher level of decision-making ability for a choice which is likely to lead to death or serious harm of the patient. Next slide, please. So the next two slides I'm just going to very quickly touch on because I know we're kind of at our time limit. So essentially, it was just to highlight, you know, within the general hospital, you know, what you might commonly have contact with is two different pieces of legislation. The first being adults with incapacity legislation, and I suppose a recent example of this being used was for a patient who had presented to a general hospital following an episode of deliberate self-harm, who was kind of confused and wandering, possibly because of the effects of medication, possibly in the context of dissociation, who was not really able to demonstrate retention information, but was kind of passively accepting all treatment that was offered. So this is someone who might be treated with adults with incapacity, but without the Mental Health Act in situ, because they can't provide informed consent, but they're not really requiring active measures to give them treatment or to keep them in hospital. Next slide, please. And the last one is, I suppose, many people might be more familiar with, is the patient who presents following potentially an overdose, saying that they do not wish treatment, is actively refusing treatment, and is also trying to leave hospital. And that's a common scenario that could be encountered where, the Mental Health Act is probably required, possibly in conjunction with the adults with incapacity legislation, because we're having to use active measures to keep the patient in hospital and to provide treatment. There was a final slide that we had, which is not here. I somehow forgot to put it in, but essentially it's just a summary slide that we wanted to say really that, the take-home message would be that capacity is complex. Consideration of capacity is very much everyone's business, and also to highlight the importance of thinking about tolerating risks versus containing risk when we're thinking about patients presenting in crisis. Thank you.
Thanks very much, both. We're going to rapidly, if we can move the slide on a wee bit just now, we're going to rapidly go into the state evaluation polls. So they'll come up on the screen like this, but they'll also be in the chat. So can everyone please, I think we've still got a good number of people on the call. If we're able to complete the polls, and we can see if we've got any time for a couple of questions perhaps afterwards, if people are able to hang on a wee bit. I think we can move the polls on, please. Perhaps while that's happening, we can look back at some of the questions. So I don't think there are any questions in currently for Nicola and Mathew. I know that there were a few more, although unfortunately, I think Andrew has answered all of his questions. Ishbel has had to leave, so there will be that'll be part of the handout. So if anyone has any questions to put to our previous speakers, please file them into the chat. So there's no questions, but there's lots of compliments for the presentation. So I guess, I'd take that any day. Okay. Right. Okay, guys. So I don't think there are any other questions just now. Ishbel's not here to answer hers. We'll deal with the Q&A bit through our handout. Just want to thank everyone for coming along today. I think again we've had a really full webinar with lots of really interesting pieces of work that are, I think, hugely important to how we progress this area of work. Hopefully there are things that we can revisit in some detail when we move on to phase 2 of the programme. This is the final of these say Q&A type webinars for phase 1 of the Personality Disorder Improvement Programme. We will be having another webinar on the 28th, where we'll talk a bit about the next stages for the programme and some of the findings from the work that we've done over the last 12 months or so. So with that in mind, I'd just like to thank everybody for coming along today, and hopefully see you all at the next one. Thanks, everyone.